Having discussed the vascular and the cellular events, now let's try to link this particular part of inflammation with some clinical aspects. Now, not that all that we read was just for theoretical purposes. At every step, if a mistake or a defect occurs in the body, there is a certain clinical disease that is associated with it. So the next thing that we are going to start with is the clinical correlation. Not only will this clinical correlation help us in linking this topic with other subjects, but also at every step when we come with a disease, same time we are also revising what all we had read. So students, the first clinical disease the first one that we are going to deal with is something known as a leukocyte adhesion defect. Leukocyte adhesion defect. Very commonly in the question, it will be abbreviated as LAD. Now just focus on the term. They are saying leukocyte means something to do with the WBCs. Adhesion means there is some problem in the adhesion. Now I want you to recall the cellular events. The first one was margination, then came rolling, then came adhesion. In rolling also there was adhesion, but that was weak. The next step is adhesion, which is actually firm. So means something in these two steps is going wrong. When it goes wrong, we call it a leukocyte adhesion defect. And remember that a leukocyte adhesion defect can be primarily classified into two. LAD1, leukocyte adhesion defect type 1, and leukocyte adhesion defect type 2, that is LAD2. Now what is important for us to know is why I have written 1 and 2 as these Roman numerals rather than otherwise. LAD1, the way you write 1 in Roman numerals means the defect is in the integrins. The defect is in the integrins. Automatically, if integrins are defective in type 1, what is defective in type 2? What was the other molecule that was helping in weak adhesion? Selectins. I want you to recall one of the selectins were the P and the E selectins. What was the molecule that P and E selectin was binding to? I hope you can recall it was the sialyl Lewis X. It is actually that what is defective. There is a defect in the sialyl Lewis X. So first difference between LAD1 and LAD2 is that the defect in LAD1, the way you write 1 in Roman numerals, the defect is in I, integrins. In LAD2, the defect is in the component of selectins, that is sialyl Lewis X. Why is there a defect in sialyl Lewis X? Because of a deficiency of enzyme that is known as fucosyl transferase. A very important implication that it has. Fucosyl transferase enzyme is deficient. Fucosyl means something to do with sugar. Sialyl Lewis X was also something to do with sugar. So if fucosyl transferase enzyme is defective, the sialyl Lewis X becomes defective, adhesion becomes a problem, LAD2. This is about a more theoretical aspect. One more thing that you need to know. Both of these, what's common is that both of these are autosomal recessive disorders. And both of these, which you can automatically understand, is if there is a problem in adhesion of the leukocyte, will the infection be cleared in such a patient? No. So the person is going to land up with recurrent infections. Now students, if a question says that there is a 4-year-old child having recurrent infections, we cannot differentiate whether it is LAD1 or LAD2. There has to be some catch point in the question, in the clinical history, that will guide you towards LAD1 or LAD2. What are those catch points? If the clinical history says that the mother said that the umbilical cord had shed off after a very long time, or you can say that the mother gives a history of delayed shedding of the umbilical cord. This is a characteristic history that you get for LAD1. Remember, when they tell you this, you're dealing with LAD1. On the other hand, if they say that the child has a very special type of a blood group known as the Bombay blood group, this means they are dealing with LAD2. This means we are dealing now with LAD2. So these two are the catch points. You will have a young child with recurrent infections, but if they say umbilical cord delayed shedding, LAD1, Bombay blood group, LAD2. Not only knowing this much is enough, we should also, as I always keep emphasizing, we should always know the why. Why is a patient of LAD2 having Bombay blood group? How is it that one way there is a problem in the inflammation or in the infection, and other way there is a problem in the blood group? So these are two totally different things, not connected, but we are going to make a connection and understand why. What was the defect in LAD2? C. Allen-Lewis X. What was that defective because of? Because in LAD2 there is deficiency of an enzyme called fucosyl transferase. This enzyme is very important for the blood groups in our body. For example, if this is a particular RBC, in red I have denoted an RBC. If this is an RBC, if the fucosyl transferase enzyme is present, every person's RBCs will have something known as the H antigen. Right? So if fucosyl transferase enzyme activity is present, H antigen is present on everyone's RBCs. That is universal. What determines whether a person is A blood group or B blood group or AB or O? What determines that? Now, a part of this H that we have, a part of this H might change into A. This person will have blood group A. Similarly, if a part of this H changes into B, the person's blood group will then become B. Third scenario, if on the RBCs we have this particular H antigen, which is now changing into both A as well as B, what will be the blood group of this person? Blood group AB. And last scenario, that if we have an RBC with an H antigen, but that H antigen changes into nothing, what is the blood group that the person will have? The person will then have O blood group. So ultimately, whether we have A, B, AB or O, it depends on H antigen converted into what, right? Also, one more concept that you know, students, already. If someone has blood group A, means that person has which antigen? We just discussed, a part of H antigen changed into A antigen. That is why the person had blood group A. This means which antibody will that person have? Anti-B. Same way, if someone has B blood group, means the person has B antigen. The antibody will be anti-A. If someone has both A and B blood group, AB blood group, means has both A and B antigen, will such a person have any antibody? No, because if antibodies are present, it will kill the own RBCs. If someone has no A and no B, what are the antigens then that person will have? That person will have both anti-A as well as anti-B. So this is a very brief of blood banking that you need to know. Going back to what we were discussing, if there is a person who has a deficiency of fucosyl transferase, if this fucosyl transferase enzyme is absent, now what will happen? Will this particular RBC have any H molecule? No, I told you for the H molecule to come, fucosyl transferase enzyme is mandatory. Now fucosyl transferase enzyme is absent, so there is no H molecule. Remember, H was the one that was changing to A, B, AB. Now if there is no H, this means that person can neither be A, nor be B, nor AB, nor O. Because there is no H antigen only at the first place. So what will it convert into? No H antigen. This type of a patient will then have every type of antibody. Anti-A, anti-B, obviously anti-AB because both antigens are absent, and also anti-H. Why? Because the H antigen is also absent. This type of a blood group, students remember, this type of a blood group is the most rarest of rare blood groups, known as the Bombay blood group. Because it was first discovered in Bombay, that is why it is known as Bombay blood group. Why is it so important to know this? Because this person has all antibodies. You cannot give this person any other blood transfusion. If a person of Bombay blood group is in need of blood, you cannot give that person any other blood group. That person needs to have transfusion with another person of Bombay blood group only. So you cannot give this person blood group A, blood group B or AB. You have to give this person another Bombay blood group transfusion only. Now you know the link. Fucosyl transferase enzyme was absent, so Bombay blood group developed. Fucosyl transferase enzyme is absent, so Cialin-Lewis X is absent, person lands up with a leukocyte adhesion defect, that is LAD2. So this was the first one that you had to know, leukocyte adhesion defect, type 1, type 2, type 1 integrin, type 2 Cialin-Lewis X. The second clinical correlate, students, that we need to know, the second one, remember we discussed something called opsonization. So this is to do with that. The name of the disease is known as Bruton's hypogammaglobulinemia. Sounds like a really long name, but what I want you to understand is try to break it into parts, and the entire summary is in this only. B for Bruton's, so B for boys. This is more commonly seen in boys. Again B for Bruton's, B for that the defect in this particular disease is in the B cell. There is a B cell defect. Hypogammaglobulinemia. Again breaking it. Hypo means a decrease. Gamma globulin means nothing but an immunoglobulin, and emia means in the blood. So there is a decrease in immunoglobulins in the blood. Why? Because there is a B cell defect, and this disease is seen more in boys. Simple, Bruton's hypogammaglobulinemia. What we need to add on to this is, what exactly is this defect? So let's say that, for example, we have an immunoglobulin. So let's go in the opposite direction. From which cell does an immunoglobulin get released? Correct. It is from a plasma cell. Plasma cell is actually is a further derivative from which cell? It is from a mature B cell. And before attaining maturity, every cell initially is immature, so the immature B cell becomes the precursor. Now go in the forward direction. We have an immature B cell, then we have a mature B cell. It forms a mature B cell. From there, it differentiates into a plasma cell. Plasma cell then forms immunoglobulins. Now I am saying that there is a decrease in immunoglobulin because there is a B cell defect. So where exactly is the B cell defect? At this step. When conversion of immature B cell into mature B cell happens, this requires an enzyme called tyrosine kinase. This step is carried out by tyrosine kinase. But in patients of Bruton's, the BTK gene is defective. Means B for Bruton's, T for tyrosine, and K for kinase. The BTK gene is defective, and when the BTK gene is defective, you can now say that the tyrosine kinase will be absent. If tyrosine kinase is absent, the mature B cell population will go down. If the mature B cell population goes down, the plasma cells go down. Ultimately, the immunoglobulin goes down. What are the implications now? If I want you to recall what I said in the beginning, immunoglobulin, particularly if you focus on immunoglobulin G, what was a very important role of this? Immunoglobulin G is involved in opsonization. Now I'm saying that the levels of the immunoglobulins are going down. So what will happen to the opsonization? It is going to become defective. So remember, Bruton's hypogammaglobulinemia, B for Bruton's, B for boys, B for B cell defect. What B cell defect? Deficiency of tyrosine kinase, BTK gene, because of which plasma cells will not form, immunoglobulins will not form. Which brings you to the other term, hypogammaglobulinemia. Immunoglobulin in the blood goes down. One implication, IgG. IgG is the most important opsonin that we had, if you remember. That IgG goes down, opsonization becomes defective. So this is the second clinical correlate that we need to know over here. Moving on, after these two diseases, the third disease that we are going to deal with now is something known as the Shediac-Higashi syndrome. Now, what we need to know over here, we came to the final step, that was phagocytosis in cellular events. Okay, in cellular events, what was happening was there was a phagosome which was moving towards the lysosome, right, and fusing to form a phagolysosome. What was helping in the movement of the phagosome moving towards the lysosome? If you can recall, over there I told you that we will be dealing with this. This is because of List protein. Now what happens if there is a defect in the List protein? Will phagocytosis happen? No, because phagosome and lysosome fusion will not occur. So there is going to be Shediac-Higashi syndrome. If there is a defect, there is defective phagocytosis, and exactly what we see in a patient of Shediac-Higashi syndrome. There are few points that we need to know over here. This particular disease is an autosomal recessive condition. And if phagocytosis does not occur, the patient will land up with recurrent infections. But then how will we differentiate this from other diseases? In every disease there is a problem in the cellular event, because of which infection the child will suffer from. So how do we differentiate this from the rest of the diseases? So remember, there are certain catch points that we have over here. If you focus on the term Shediac, C I will take up for CNS. These patients also have neurological deficit. Next, focus on the next two, H and E. This stands for hemorrhage. When will a person have hemorrhage? When there is some defect in the platelets. So these patients are also going to have platelet defects, leading to bleeds. The third one, which you already know, is a decrease in the immunity. Right? That is why the person will land up with recurrent infections. And lastly, one of the most striking and the catch points that we have over here, the catch points that we have in this particular thing, is that A will now stand for albinism. A will stand for albinism. So these patients are going to have a decrease in the melanin. That is why the pigmentation of the body is going down. Hypopigmentation, albinism, because decrease in melanin. Also very commonly you will see that the examiner will say that the child had silvery grey hair. Silvery grey hair. Why? Because again, hair pigmentation responsible is melanin. Melanin production goes down, skin pigmentation goes down, hair pigmentation goes down, silvery grey hair. So if you can remember the term Shediac, from the term Shediac, one or two of these will definitely fit into the clinical features that the examiner has put up, and then you will be able to pick up that this is a patient of Shediac Higashi. But as I've repeatedly said, the trend nowadays is of image-based questions. So there is one thing that you need to know on the peripheral smear examination of this particular case. In this case, the peripheral smear, for example, if this is the neutrophil, the peripheral smear is going to show extremely large granules, or you can say the giant granules. The giant granules, a very important finding that you see in a patient of Shediac Higashi syndrome. So we must be able to identify these particular granules. Students, this is the image of Shediac Higashi syndrome that you need to be aware of. As you can appreciate, this is a peripheral smear showing these three large cells, and I hope you can appreciate a cell having multiple nuclear lobes becomes a neutrophil. What is very striking in this neutrophil is that these granules that are present in the cytoplasm, these granules are abnormally large, or I can say these are the giant granules. These are the giant granules. And this is a very characteristic feature that you see on the peripheral smear, of a patient of Shediac Higashi syndrome. So instead of giving you a theoretical question or a question that is related to the clinical history, they might just give you an image of the peripheral smear of a patient, and just by looking at this, you need to remember that these giant granules that you see in a neutrophil are very characteristic of Shediac Higashi syndrome. Okay, so students, we've till now discussed three very important clinical correlates. The first one was leukocyte adhesion defect, which was of two types, 1 and 2. In 1, there is integrin defect. In 2, there is Cialin-Lewis X defect. Second disease was Bruton's hypogammaglobulinemia. B for Bruton's, B for Bruton tyrosine kinase defect, B cell defect you can say in other words. And hypogammaglobulinemia means a decrease in Ig or immunoglobulin, specifically IgG. So the opsonization was defective. The third disease that we just discussed was Shediac Higashi syndrome, in which there is a defect in the protein, the LYST or the lysosomal trafficking protein, because of which the patient will then not undergo phagocytosis and will suffer from recurrent infections. What was the catch point in the history? Decrease in melanin, albinism, silvery grey hair. And the image that you need to remember are the giant granules. Moving on and going to the fourth clinical correlate that we need to know over here, there is a disease known as CGD. This is an abbreviation for chronic granulomatous disease. Chronic granulomatous disease. Now what do we need to know in this? What is the main defect? Now going again back to phagocytosis, what was the main enzyme or the most important enzyme for phagocytosis? That was, you are right, it was NADPH oxidase. NADPH oxidase was the main or the most important enzyme. So in this disease, there is a deficiency of NADPH oxidase. So main enzyme absent, phagocytosis is going to suffer, killing is going to suffer. What we need to know that this disease can manifest in two forms. Either it can be X-linked recessive or it can be autosomal recessive. X-linked recessive and autosomal recessive. What are the differences that you need to know, students, is remember we had studied that NADPH oxidase is going to have a membrane component and it is going to have a cytoplasmic component. So when there are different types of defects in the membrane and in the cytoplasm, there are different inheritance that you need to know. X-linked recessive is mainly a defect in the membrane component of NADPH oxidase. And autosomal recessive is mainly a defect in the cytoplasmic component of NADPH oxidase. Now the gene that is defective in X-linked recessive is GP91 FOX. What is FOX? Phagocyte oxidase. NADPH oxidase is involved in phagocytosis, so phagocyte oxidase, GP91. How will we remember this? This is X-linked recessive. This is the way we write 10, which is equal to 9 plus 1. So GP91 FOX gene will be defective in X-linked recessive form. In autosomal recessive form, GP47 and GP67 FOX are going to be defective. GP47 and GP67. So students, in the exam you should not confuse that which GP defect was seen in which inheritance. So how will you remember this? X-linked recessive, X you can remember it as a 10 and that is equal to 9 plus 1. So GP91 FOX is what is defective in X-linked recessive. 47 and 67 then become for autosomal recessive. So now you've understood the basic concept that NADPH oxidase deficiency is going to happen. So automatically what you can yourself tell me is that clinically the patient is going to suffer from recurrent infections. In the clinical features, the patient will suffer from recurrent infections. If these infections go on for a really long period of time, remember the term, what is the name of the disease? Chronic granulomatous disease. So if this goes on for a longer time, for a chronic time, what will it result in? The formation of granulomas. That is why the name chronic granulomatous disease, because if it goes on for a considerable time, it is going to result in the formation of granulomas. Now next, students, is one point which is going to characterize this disease from the rest of the diseases. Patients of CGD or chronic granulomatous disease are going to have particularly infections with catalase positive organisms. This will be one of the main hints in the question that will tell you that they are talking about CGD, because till now all the diseases that we have studied, all of them have recurrent infections because all of them are defects in the events of inflammation. So this disease is separate, is distinct because of catalase positive organism infections. Again, we can't leave anything just without knowing why. You need to know the reason. Why is it having infections with catalase positive organisms only? Example, Staphylococcus. That is because I want you to now recall what was happening in this phagocytosis. Oxygen was getting converted into superoxide. By which enzyme? You are right. It was going into superoxide by NADPH oxidase. Superoxide then converts forms hydrogen peroxide. Hydrogen peroxide then combines with MPO and chloride to form hypochlorous acid. I hope everyone can recall this pathway of phagocytosis. But now what is the problem here? There is deficiency of NADPH oxidase. But remember students, there is some amount of oxidase activity that is present in the bacteria themselves. in the organisms some amount of oxidase activity is present. So some amount of superoxide will still be formed. It is not that it will not be formed, because organisms themselves have oxidase activity. Although the amount will not be as high as it would have been formed if any DPH oxidase would have been present, but a small amount will be present. This small amount will then later on form H2O2. So it should form HOCl and it should still cause some killing of the bacteria. But it is not happening so. Why? Because despite formation of superoxide, when H2O2 is formed, the catalase positive organisms are going to use their catalase and they are going to break down the H2O2 into water. So now, will this H2O2 later on form hypochlorous acid? No, because the catalase positive organisms have broken this H2O2. A catalase negative organism would have not broken this down, resulting in the formation of HOCl and resulting in its own killing. That is why patients of chronic granulomatous disease suffer only from catalase positive organism infections, for example, Staphylococcus aureus. Now, once you've understood the concept of this particular thing, the question that tends to be a favorite with the examiners is how are you going to do the diagnosis? And remember students, there is one test, NBT. So 3 letters N, B and T will be a test for which disease? The disease having 3 letters C, G and D. So 3 for 3. What you need to know is what is this NBT? This is nitro blue tetrazolium. NBT, nitro blue tetrazolium. Now students, the basic underlying concept of this particular test is that nitro blue tetrazolium is a dye which is originally, in its original form, it is colorless. It does not have any color. But on exposure to free radicals, when it combines with free radicals, for example, superoxide and so on, this results in the formation of a product known as formazan. And this formazan basically has a blue-purple color. Now students, if a normal cell, if you just consider a normal cell, not any pathology, not any disease, in a normal cell, NADPH activity, NADPH oxidase activity is normal. Free radicals are being formed. So normally what will you expect? If free radicals are being formed, the colorless compound will convert into a color. The development of a color indicates normal. But if we have a patient who is of chronic granulomatous disease, that is NADPH oxidase is deficient, will the color change happen? No, because there are no reactive oxygen species, there are no free radicals, so no color change, so there is going to be no color change. The dye was initially colorless, it is still going to remain colorless. So this is important to know. If the color changes, it is normal. If the color is remaining the same, colorless, means the person is having an NADPH oxidase deficiency. What students you can easily gather from this is, what kind of a test will you call this? Qualitative or quantitative? This is depending on the color. Color present, color change seen or not seen. We are not quantifying or measuring anything. This might vary from one person to another. So I will call this a qualitative test. Right? So NBT for CGD is a qualitative test. It is a screening test that can be used. That is the first test that you need to know, NBT for CGD, which is a qualitative test and a screening test. The second is basically a quantitative test. So you just need to know the name of the test. Quantitative test is known as DHR, that is dihydrorhodamine. Dihydrorhodamine. This is a molecule that is going to be tested via a technique known as flow cytometry. Flow cytometry. So overall, if you want to sum up chronic granulomatous disease, remember it is a main defect in NADPH oxidase, which can either be X-linked recessive or autosomal recessive. X-linked recessive, X for 10, so you're going to have GP91 FOX defect. Autosomal recessive, GP47 and GP67 FOX defect. Patient will have recurrent infections, particularly with catalase positive organisms. The qualitative test that we have is NBT, nitro-blue tetrazolium, where color change is normal, no color change or remaining colorless is abnormal. The quantitative and thereby the better test, if you are asked to select in the exam, better will always be the quantitative test where you are quantifying DHR, dihydrorhodamine, by flow cytometry. So this was the next clinical correlate that we had done, the fourth one. The fifth one is very similar. What if the person is suffering from MPO deficiency? What if the person is suffering from MPO deficiency? Now, for this, I just want you to recall, oxygen will first form superoxide. By which enzyme? I hope this we have done multiple times, NADPH oxidase. Superoxide will then form H2O2. H2O2 in the presence of MPO and chloride forms HOCl. So this is something we've repeated multiple times. This is the basic phagocytosis. Now students, what if someone has an MPO deficiency? Will this pathway occur? No. So then this patient will suffer from recurrent infections. But the catch point over here is, this patient will have recurrent infections with both catalase positive organisms also and catalase negative organisms also. Why? Because if there is a catalase positive organism, the organism will break down H2O2 by catalase. Killing will not happen. Even if the organism is catalase negative and H2O2 is formed, will it be able to further form HOCl? No, because MPO is deficient. So either ways, both catalase positive and catalase negative organisms can result in disease or infection in a patient of MPO deficiency. Please recall, MPO was myeloperoxidase. This is a very important enzyme in the H2O2 MPO halide system that we have. So these were a list of all the clinical correlates that you need to know when you are dealing with the events of inflammation.